All right, good afternoon, everyone. Welcome to our monthly Firefighter Cancer Initiative seminar series. We'll go ahead and give just a couple of minutes for folks to trickle into the webinar today, and then we'll go ahead and begin. We'll introduce our speakers and then just do some administrative check-ins at the beginning. So please go ahead and make yourself situated, and we'll get started in just a minute. Okay, it is 12:03, and we'll go ahead and get started with our Firefighter Cancer Initiative seminar series. Good afternoon, everyone, or good morning, wherever you're joining us from. My name is Alberto Caban Martinez. I'm the Deputy Director of the Firefighter Cancer Initiative, and along with my colleague, Dr. Natasha Schaefer-Sali, as well as Dr. Aaron Kovitz and Dr. David Lee, we welcome you to our monthly installment of the Firefighter Cancer Initiative series. This is our opportunity to share with you updates on the individual research projects that we're doing as part of our FCI initiative, as well as an opportunity to interact with the scientists and ask them questions about what's going on. So for today's seminar series, I am really excited to present to you our draft cohort study. This was a study that was initiated by the FCI through motivation by one of our local partners, which my colleagues will explain in just a minute. And it's really one of the examples of where firefighters really drive the scientific agenda of what's studied and bring it to light. And so today's seminar series is devoted to pulmonary health and lung health. This is a long-term project, so it'll run for quite some time, as it is a cohort where we're trying to understand the respiratory health of firefighters and the exposures that they encounter both through training and through work that may impact that health. For today's presentation, we have our doctoral student, Ms. Hannah Kling, who is a PhD in prevention science student. And she's the brave soul that said she would take this project on when the county asked us to initiate a project on respiratory health, along with our research associate, Addison Testoff, who will be tag teaming this afternoon. So I will remind everyone that there's an opportunity to paste questions in the Q&A, and we'll entertain them towards the end. So if you either want to remember to raise your hand towards the end of the presentation and ask questions, or if you want to pop them into the Q&A session, we'll entertain them towards the tail end of the session. All right, with that, without further ado, I'm really excited to introduce Ms. Hannah Kling and Mr. Addison Testoff to tell us a little bit about the preliminary and baseline data available to us in the draft cohort study. And so Hannah, I'll trouble you just to unmute yourself to make sure that I think you may.
There we go. Can you hear me?
Yeah, loud and clear.
Okay, great. Well, thank you for the introduction, and hello to everyone. Thank you for joining today. Today I'll be presenting to you with my colleague Addison this new study we started in June, and it's called the Direct Respiratory Assessment of Firefighter Tactics Cohort Study. We also just call it DRAFT because that's a mouthful. So DRAFT is the name of the study. And before we get started, we'd like to acknowledge a couple of entities here. First, this study is funded by the state of Florida appropriation. We'd also like to thank the research team, Dr. Caban Martinez, Dr. Natasha Schaefer-Sali, and also Dr. Shirin Shafazan, who helped initiate this project. We'd also like to thank the state of Florida Fire Marshal's Office, as well as Miami-Dade Fire Rescue and their local 1403 for basically the initiation of this study. They expressed interest that they were interested in this and had some concerns. Maybe their local firefighters wanted to learn more about their respiratory health and came to us, and behold, the draft study was created. So the pulmonary health of the Florida firefighter workforce is unknown. We see that in Virginia, there's a recent study published by Matthias in 2020 that looked at 600 something firefighters in Virginia and found that the pulmonary health of those firefighters decreased over 5 years. And then we also see that wildland firefighters are at an increased risk for lung cancer and cardiovascular disease mortality. But these two types of firefighters are a little different than firefighters that you might find in South Florida. Down here, we have hurricane codes, so our buildings are made of concrete. These might be different than, for example, like a firefighter in Boston, where they have wood buildings and things, the materials that are burning are different. So like I said before, the pulmonary health of Florida firefighters, these urban and suburban firefighters, is unknown. Literature on lung cancer among US firefighters is mixed, with some studies suggesting that the chance of lung cancer diagnosis or death increased with the amount of time spent at fires. And in addition, exposure to catastrophic events, these are known as non-routine firefighting, such as events like 9/11 or even the more recent Surfside building collapse here in South Florida. These type of events significantly increase the rate of decline in firefighter lung function. But the rate of change of this lung function and the association with just routine exposures is unclear. Firefighters are also at a risk for hazardous occupational exposures. These include polycyclic aromatic hydrocarbons, also known as PAHs, and these are carcinogenic exposures, and they increase risk for a decrease in pulmonary function and increased risk for respiratory cancers. Pulmonary function has also been seen to decrease over time on the job for firefighters, and the obstruction of airflow in medium airways can also happen over length of time in the job. Radon exposure higher than 4 picocuries per liter can cause lung cancer in non-smokers over time, and this exposure is unknown among firefighters. I'll talk to you a little bit more about radon a little later. And firefighters are at an increased risk for being exposed to diseases such as COVID-19. They're on the front lines facing patients, taking them from their home to their hospital. So they're at an increased risk for being exposed to these types of diseases. And as we've seen over the past couple of years, this can cause death through respiratory systems. It is a SARS virus. So they're also at a greater risk for being exposed to those types of diseases. So the draft cohort study was created to be a prospective longitudinal cohort study. This just means that we follow the same group of firefighters over time. And this specific study is a total of 12 months. And the aim is to assess the pulmonary health and occupational pulmonary health risk exposures of Florida firefighters. And like I told you before, a South Florida Fire Department expressed interest in this type of study and invited us to conduct and recruit firefighters in their department, as well as some other Florida fire departments down here. We've been able to recruit with them as well.
Awesome. So why is this important? So one of the main important things is we want to inform medical providers of respiratory exposures and lung diseases that need to be monitored among firefighters. And 2, to inform opportunity for workplace interventions. So for inclusion and exclusion criteria, inclusion criteria is they have to be at least 18 years or older to participate, fluently speak and write English, and currently working as a firefighter, first responder for at least 3 months. Exclusion criteria includes does not meet the inclusion criteria, plans to move away to a new fire department, active or suspected with a respiratory infection, recent surgery within the last 6 weeks, myocardial infarction within the last 30 days, coughing up blood, current or history of abdominal, thoracic, or cerebral aneurysm, recent concussion, pregnancy, or already participating in a COVID-19 clinical trial.
So we started the study with enrollment and baseline assessment, and this included a number of data collection, like not only surveys, but we also did a physical examination and did a pulmonary function test with firefighters. So we'll go through each of them. First, the survey assessment included questions about sociodemographic information, we want to be able to characterize who we're actually studying. We also have a respiratory assessment form, which asks about medical conditions, respiratory symptoms, and also smoking history. We offered them the Pittsburgh Sleep Quality Index, also known as the PSQI, and this asks questions about sleep apnea, sleep quality, and sleep disturbances. Then we asked about respiratory. We have a respiratory questionnaire in there called the ATS-DLD, and this contains questions regarding frequent and chronic respiratory symptoms, including like cough, phlegm, wheezing, shortness of breath, those sorts of things. And then finally, we also asked the sample about their rhinitis or their allergies. After that, we did a short non-invasive physical exam. The first thing we did is a SARS-CoV-2 antibody screening test. If a firefighter had positive IgM antibodies, we're going to be doing a lung function test and blowing air. We don't want to expose not only the study team to COVID, but also other participants who might be in the room. In addition, they did a throat examination, which is the Mallampati score that can be given. You can see it on the right-hand side. There's class 1, class 2, class 3, and class 4. And by looking in the throat, you can get a good perspective if a participant has obstructive sleep apnea. We also collected blood pressure, height, weight, oxygen saturation, waist and neck circumference, and then also body temperature. Then finally, we collected the exhaled breath, and we did a pulmonary function test. The picture that you see on the left-hand side is the exhaled breath tube. And this is actually really neat. Well, I think personally, this is subjective, but a really neat way to collect exposures. So we're concerned about firefighters' exposures, which are typically what I said before, those PAHs and other type of aromatic hydrocarbons in the field. There are other types of compounds that the lab looks at, especially after responding to a fire. So we did this, we collected their exhaled breath condensation in this tube. It's a cold tube. We put it in the freezer, and then there's a plastic tube that goes inside, and they're able to breathe through it, and it collects the from the warm breath. It creates condensation on the inside of the tube. And we're able to basically see if firefighters' exposure to toxic compounds through a variety of routes, if they're potentially reflected in the compounds of their breath. And then so we did it at baseline, and then we're gonna follow up after fire training, after they're at a burn, and collect their exhaled breath again to see what their exposures are. Then in the middle picture, we have a spirometer, and we have partnered with Zephyr RX to do this study. It's really neat because the participants are able to do this test on their own and take this home. So we only see them at baseline, and for the rest of the year, they're able to do this test by themselves. On the right-hand side, you can see that this, it's actually connected to an app on their phone, and it walks them through the entire pulmonary test. And this is an example of what it says. You have to close your lips around the mouthpiece, completely fill in your lungs, blast out and completely empty your lungs for a long time. The app will tell you, keep going, keep going. And then finally you inhale again. And that's what a pulmonary function test is. And then in addition, we gave each firefighter 2 radon kits and 2 environmental sampling wristbands. Radon is a naturally occurring gas that comes from the earth and the breakdown of the rocks. And you can see in this picture here on the left-hand side of the house, sort of how the radon comes up through the soil, through the bedrock. And then on the picture on the right-hand side, this is a map of radon zones in the United States. It affects different areas and different seasons. The radon levels can change. And though Florida has a low amount of radon exposure, if you look at Miami-Dade, it's actually orange. And so we have a medium level of radon exposure here, maybe primarily because of the construction and the breakdown of the sediment here in the area. So we ask them to collect their exposure through these short-term radon air tests. And they get 2 at baseline, 2 at the 6-month follow-up, and 2 at the 12-month follow-up. and every other month they only get one. So at baseline, they have one for their home and one for their firehouse. They take it out of the package, leave it there for 3 to 7 days, and then they're able to just send it in without any postage stamps. And then the lab will find results and then send results back to us. At baseline, they do one in their home and one in their firehouse, but every other month, besides the baseline 6 and 12-month follow-up, they do it in their firehouse. And then we also give them 2 wristbands to wear. You'll see a picture of it on the next slide when I get there. These bands have been treated to collect carcinogenic exposures, similar to like the exhaled breath, but some, exposures can enter you dermally through the skin. And so this bracelet or wristband helps to collect that, and we can get an idea of what exposures they're being exposed to on a day-to-day basis. So we give them one to wear on shift for 24 hours. They have to take it off if they shower or swim. And then they also have another one to wear off of shift for 24 hours. Again, this one is at baseline 6 and 12-month follow-up. Every other month, they only get one. And this is to be worn while they're on shift at the firehouse. Then they're mailed this every single month to participants. In the mail, they get from us a wristband and a radon kit. They're given prepackaged postage to send it back to the labs. And then in addition, we ask them to do a monthly pulmonary function test. They were able to take that device home, and it's connected to an app on their phone. And then on our end, we can check on our dashboard to see if they've done it or not. And then they also do a monthly survey, which is emailed to them through a link. And this is the Pittsburgh Sleep Quality Index and the rhinitis questionnaire. Both of these surveys ask about their this within the past 30 days. So it makes sense to do it with them monthly. And then we will now get into some preliminary study findings. Like I said, we just started this study in June, and it lasts for 12 months. So, we'll have more for you at the end of the study, but we have some baseline results that we can share with you today.
Okay, so this graph right here is the sample prevalence of self-reported doctor-confirmed respiratory diseases at enrollment among participants of the draft study. So on the left, we have the percentage of our cohort, and on the x-axis, we have various respiratory diseases that were self-reported. So 20.2% of participants reported they have bronchitis attacks, have had bronchitis attacks. 5.2% have had chronic bronchitis. 20.8% have had pneumonia. 7.4% have had hay fever, and 14.7% have had asthma at some point. So here, before I kind of explain the baseline results for the spirometry exam, just to kind of go over how the PFT works, is we issue each participant their own pulmonary function device. And then when they have it, the way the test works is that they breathe in, then they push air out as fast as they can for a few seconds, and then they breathe in again to end the test. And that's one trial. They'll do as many as they can when we meet them. And so in order for the results to be included, we need 3 acceptable results according to ATS acceptability. And then after that, if they have 3 acceptable results, then we included them into this chart that we have here. So we have 79 firefighters that had at least 3 acceptable results. So if you look at the bottom one, we have FEC divided by FEV1 divided by FEC. So what we do is we take the best FEV1 divided by FEC, we take the 3 best, and we take the average of that. FEV1 stands for forced expiratory volume 1, and FEC stands for forced vital capacity. So FEV1 is the amount of air that you push out in the first second of the test, while forced vital capacity, FVC, is the amount of air that you push out during the whole test. So that ratio, if it is above 0.7, then it's considered a normal result. If it's below 0.7, then it is considered an abnormal result. And then the 4 above, you'll see FEV1 less than 80% of predicted. You'll see FEV1 less than 70% of predicted. You'll see FEC less than 80% of predicted, and you'll see FEC less than 70% of predicted. The predicted values are based off of GLI 2012 reference values. And so what we do is we take the FEV1 values and the FEC values from their best 3 FEV1 FEC average values, and we divide them by, or we compare them to those predicted reference values. So if they have less than 80% of that predicted value, then they're considered to have an abnormal result for that day. So we had 14 out of 79 had an FEV1 less than 80% of predicted. We had 4 that had less than 70% of predicted for FEV1. We had 9 less than 80% for FVC, and we had 70%. We had 4 that had less than 70% for FVC. Next slide.
So another thing we looked at is the association between pulmonary function test results, which was that bottom row we saw in the previous table, the FEV1 divided by FVC ratio. So these tests and the amount of fire runs that the firefighters went on. So what we see here is on the left-hand side, these are the number of people we compared to the two groups, people who had not obstructive, but abnormal FEV1 over FVC ratios, and those who did not. And those who had obstructive or abnormal results less than 70%, they had a total of about 4 fire runs they went on in the past month, while those who did not had actually more fire runs. So we wanted to see if this was a significant difference between these two groups. And if you look down here, the significance should be less than 0.05, and it's not. So this is not a significant difference. If you want to just, look at this as a whole, you'd think that those who were exposed to a lot of fire and had more, smoke exposure had worse values, or not worse values, but there are more people who would have an abnormal result, but it's actually the opposite. So we're not sure why this is, but we'll talk about that in a little bit. And then finally, the last examination that we did is on the Pittsburgh Sleep Quality Index. This index looks at 7 components of sleep. The first is subjective sleep quality. Then we have sleep latency, sleep duration, habitual sleep efficiency, sleep disturbances, use of sleeping medication, and daytime dysfunction. So the participants answer questions about these types of components within the questionnaire, and then there's a mathematical equation that you can do to give them an overall global score. And this score can be between 0 and 21. 0 indicates no difficulties in all of these areas, and 21 indicates severe difficulties in all of these areas. And in addition, if a participant has a value greater than 5, this is considered to have significant sleep disturbances. And here are our results. You can see that this is skewed a little to the right, but right here is this line considered significant sleep disturbances because they have a score greater than 5. So here we have 13 firefighters with a score of 6, 10 firefighters with a score of 7, and you can see the highest score we had was 17. So overall, our fire runs do not appear to be associated with ventilatory defects. And this is possible that those with these low FEV1, FVC values just may not go on fire runs as often. Maybe they know that they have asthma or something wrong with their lungs, so they actually don't go on the fire calls as much. That's a possibility. We don't know, but that could be a possible explanation for that. We found that approximately 57% of our firefighting sample are considered to have significant sleep disturbances, which you saw in the previous slide. And some future questions that we will want to ask is there an association between respiratory disease, which is, having bronchitis, having hay fever, some of those other diseases that Addison reported. So is there an association between those diseases and then low ventilatory defects? And then we also want to examine if there's an association between collected environmental exposures, such as what we collect on those wristbands, those PAHs, and ventilatory defects. And like I told you before, we're currently just in the 3rd month of data collection. Today is actually the last day for those who were enrolled on June 29th to, this is their 2nd follow-up. So now we're moving into the 3rd follow-up out of a total of 12 months. So, and overall, by the time the study is done, we hope to have a better understanding of firefighter pulmonary function, as well as environmental exposures that can contribute to lung damage among firefighters. And that's it. Do we have any questions?
So thank you very much, Hannah and Addison, for a really great presentation, sort of summarizing the cohort and providing some preliminary results of what's been collected so far. I realize it's been really fast since you initiated this in June. We'll turn to our audience now of attendees and see if there's any particular questions that you would like answered by the presenters. You may type them into the Q&A chat room on your screen, or feel free to unmute yourself and ask away. I do see one question already in our Q&A asking about the availability of slides. And yes, this recording and the availability of slides will be made available through the FCI social media platform. So those will get disseminated there. So let me just pause for a second and see if there's any questions from the audience, either out loud or anybody wants to post in the chat. Okay, so I had a question for you both, since you've been in the weeds and the details of this individual cohort study. What has been some of the challenges with implementation of spirometry in the field? Even now, given during the time of COVID, could you share with the audience, like maybe things that worked and things that didn't work as part of the respiratory disease? Of course, this is a long study and it's probably challenging to initiate during COVID, but what were things that maybe worked from your perspective and didn't work for spirometry testing?
Well, I have to say the convenience of this test, because we have this handheld device, made it so easy to take it into the field. We just were able to take the field, take it with us into the field, hook their phone up via Bluetooth, which we did have some problems with. Sometimes the spirometer wouldn't connect to the Bluetooth, but just with sitting down with the participant and working that through, everything would turn out fine. But then them being able to take it home, I think, is so convenient. We don't have to meet up with them every month to do it. We can do a Zoom call, which is, I didn't get into the weeds of that, but to walk them through it if they have a hard time. But the convenience of them being able to take the spirometry test home, I think, is really helpful.
Thank you. Could you, I noticed when we looked at the self-reported sleep quality index through the PSQI, there you actually have almost greater than half of your sample has some sort of, potential concern with sort of like their sleep. Could you walk through like maybe why we're seeing some of that? Like what are some of the reasons that you may have sort of high self-reported poor sleep quality values?
Yeah, besides looking at the respiratory diseases that Addison showed us before, that's something to look into to see if those respiratory diseases affect their sleep. But we also know that firefighters are actually overweight and obese as well. And that obesity and being overweight can push on, your lungs and also your throat, and create sleep problems like sleep apnea. So it will be interesting to see if we, can calculate maybe BMI, or to see some of those types of characteristics, and see if there's an association between sleep and BMI. That's also an interesting question. That's my prediction.
It occurs to me that, you initiated the cohort study during the summer period, which tends to be a little bit more hot and muggy. So because this is a cohort and you'll follow these firefighters over the year, month to month, presumably there may be changes in some of these like respiratory metrics that you're doing with weather changes and maybe allergies and allergy season and such. Mm-hmm. How are you taking into account, for example, those changes into that?
Well, we test for them monthly. So if something does happen with their sleep, the sleep and the rhinitis are both the monthly surveys that they take. So because they do take it monthly, we can look at over time how both of these things are affected throughout the entire year.
Yeah, absolutely. You have a comment in the chat from Dr. Lee that maybe you want to address, but he's basically saying that a potential approach here could be to stratify the sample into older versus younger firefighters to maybe unpack the association between lung function and the number of fire runs. Do you want to maybe comment a little bit on?
Yeah. So this is something we actually looked into as well. We did a short analysis. What was interesting is the firefighters that had abnormal FEV1 over FVC values were actually younger. So this is, we're not quite sure why, maybe we need to look at the data a little bit deeper. That was just, like a sort of surface examination. So yeah, that's an interesting question. And that was an interesting, little quick finding we found as well.
Yeah, it is just a baseline one-time snapshot.
Yeah.
The cohort over time will hopefully give some insight into that. But it was very interesting that it's actually a slightly younger age, I think, right? Like 2 or 3 years younger than those without any ventilatory defects. Okay, any other comments from or questions from our audience? Okay, well, I want to thank again both Hannah and Addison, and again the entire draft research team. This is actually a very large team that's supporting all the data collection, given the various assessments that are done throughout. So on behalf of Dr. Sally, Dr. Kobitz, Dr. Lee, and I, we're really thankful to you, Hannah, and to Addison for leading this effort for this cohort study. And we're excited to learn, what this longitudinal data will provide. I know you're interested in comparing some of this to American lung studies to be able to see how firefighters are different from the general population. So we look forward to the future of this cohort and the data you collect throughout the year. All right, thank you everyone. And we'll see you next month for our upcoming seminar series, which I should know who's the next presenter, but our social media team will be sending that out with our next presenter slide. All right, wishing everybody a great day. Take care.